Welcome, everyone. Look, we all know drug-resistant tuberculosis is one of the toughest topics in postgraduate medicine, both in the clinic and definitely in your exams. So in this explainer, we're going to systematically break down DR-TB, giving you that high-yield, structured knowledge you absolutely need to not only master this for your practice, but to really nail those exam questions. We're going to tackle this in 6 logical steps. We'll start with the absolutely essential definitions and mechanisms, then walk through diagnostics, drug classifications, and the very latest treatment regimens. We'll wrap things up by covering the critical management of side effects and the programmatic care that actually ensures a cure. So let's start at the very beginning with the foundation, the definitions. All right, first things first. Getting the definitions of drug-resistant TB absolutely right isn't just for show. It literally dictates every single clinical decision we make. And you can bet it's the classic starting point for any long-answer exam question on this topic. So let's frame our thinking around this one core question. Understanding these classifications is like learning the language of DR-TB. Each definition builds on the last, and together they create this really clear hierarchy of the challenges we face. We'll kick things off with rifampicin resistance, or RRTB. This is our sentinel marker, our first major red flag, and here's why. Resistance to rifampicin is incredibly easy to spot with our rapid molecular tests, like the CBNAT. That's the cartridge-based nucleic acid amplification test. Since it almost always travels with isoniazid resistance, any patient with RRTB is immediately managed as if they have MDR-TB. It's our first and most important warning shot. Next up, the classic one, MDR-TB. This is where the organism is resistant to both isoniazid and rifampicin. The key thing to grasp here is that we've lost our 2 heavy hitters, the most powerful drugs in our first-line arsenal. This just completely changes the game, forcing us onto longer, way more complex, and often more toxic second-line regimens. Building on that, we get to pre-XDR-TB. So think of this as MDR-TB, but with an extra layer of danger. Now, we've also lost resistance to any fluoroquinolone, drugs like levofloxacin or moxifloxacin. These are the absolute cornerstone of modern second-line treatments, so losing them makes building an effective regimen so much harder. And that brings us to our most formidable opponent, XDR-TB. Now, pay very close attention here because the definition was updated in 2021, and this is a massive exam point. It's no longer about the old injectable agents. The new definition is MDR-TB plus resistance to a fluoroquinolone plus resistance to at least one of the other core Group A drugs, that's bedaquiline or linezolid. This is, frankly, a clinical nightmare because it means the bug is resistant to the most powerful parts of our best all-oral regimens. This table just lays it all out so clearly. It really shows you that ladder of resistance. Just follow the yes answers across. Rifampicin resistance is the constant, right from the start. Then, for MDR, you add isoniazid. Pre-XDR adds the fluoroquinolone. And finally, XDR-TB lights up the whole board. It checks every single box. Seriously, if you can draw this table from memory in an exam, you're in a great spot. Okay, time for the molecular genetics, and examiners absolutely love this stuff. You have to memorize these gene-drug pairings. For rifampicin, the key gene is ARPO-B. For isoniazid, it's a 2-part story. CAT gene mutations give you high-level resistance, while NHA mutations cause low-level resistance. Fluoroquinolones, think GRR and GRB. And for pyrazoniamide, mutations in PNCA mean the prodrug just never gets activated. Knowing these is simply non-negotiable. All right, we know the definitions. But how do we actually find these resistant bugs? Let's move on to our diagnostic toolkit. The huge story here has been the shift away from slow, old-school culture methods toward making rapid molecular tests the first thing we reach for. So we've got 2 main ways to do this. Genotypic testing using tools like CBNA8 is incredibly fast. We're talking results in hours because it's looking for those gene mutations we just talked about. This is why it's our go-to initial test. On the other hand, you have phenotypic testing. This is the traditional gold standard where you actually grow the bacteria with the drug. It's thorough for sure, but man, is it slow. It can take weeks. So the trade-off is really simple. It's speed versus absolute certainty. Now, this slide shows you the national program's diagnostic algorithm, and it's all about a test and treat philosophy. The key takeaway is this. Every single notified TB patient now gets screened up front with a rapid molecular test. If that test flags rifampicin resistance, that's step 3, we immediately start them on an MDR-TB regimen.
We do not wait weeks for a culture result. That one rapid test drives the first, most critical treatment decision, while other tests like LPAs and culture are sent off to help us fine-tune the regimen later.
So let's take a closer look at one of those follow-up tests, the line probe assay, or LPA. The easiest way to think about it is as a molecular antibiogram. It basically takes the bacterial DNA, makes a bunch of copies, and then uses these special probes on a paper strip to see if the key resistance mutations are there or not. You literally see the results as colored bands on a strip, giving you a super fast genetic profile of the bug's resistance. And there are two main types of LPA you need to know. The first-line LPA looks for resistance to isoniazid and rifampicin by targeting those genes we memorized, Catchy, INHA, and RPOB. Then, for a patient who is already confirmed MDR-TB, we use the second-line LPA to check for resistance to fluoroquinolones, targeting GYRA and GYRB. You see how it all connects? The diagnostic tools are looking for the exact molecular changes we just learned about. So once we've figured out the resistance pattern, our next job is to build a brand new, effective regimen from the ground up. And that all starts with the strategic classification of our anti-TB drugs. This isn't just some random list. Think of it as the blueprint for building a life-saving treatment plan.
Okay, this slide is absolutely 100% critical for your exams. The WHO groups drugs into A, B, and C. The easiest way to think of this is like a recipe. Group A drugs are your core, non-negotiable ingredients, a fluoroquinolone, bedaquiline, and linezolid. You must include all three if you can. Group B drugs, clofazimine and cycloserine, are your next best additions. You add one or both to that Group A core. And finally, Group C are just add-on agents, which you only use to fill out the regimen if you can't use something from A or B. The principle is so simple and logical. Start with A, add from B, and only then top up with C to build a powerful regimen of at least 4 to 5 effective drugs.
So, armed with our drug classification, we can now start building the actual treatment regimens. And the big story in this modern era is the move away from those painful, toxic injectables towards highly effective, all-oral strategies. This here is our standard, individualized, longer regimen, and it follows that A plus B principle perfectly. We start with all 3 Group A drugs, a fluoroquinolone, bedaquiline, and linezol, and then we add at least one from Group B, which is usually clofazimine. This makes sure we hit the bug hard right from the start with at least 4 drugs that are likely to work. The total treatment time is typically 18 months, but we might extend that to 20 months for more complex XDR-TB cases. Now, for some patients, there is a shorter, standardized option that lasts about 9 to 11 months. But, and this is a big but, the eligibility criteria are super strict because this regimen is much less forgiving. The patient can't have had any significant prior treatment with these second-line drugs, and most importantly, we have to know for sure that there's no fluoroquinolone resistance. If they tick all those boxes, then they go on a pretty intense initial phase, followed by a simpler continuation phase. And now for the real game changer, the BPAL regimen. This is a truly revolutionary all-oral 3-drug cocktail, bedaquiline, the new kid on the block, pritomanid, and linezolid. And what does it do? It can cure some of the most resistant forms of TB in just 6 months. Incredible. This topic is extremely high yield, so listen up. The power of BPAL is just astounding, with cure rates around 90%. But that power comes at a steep price. The toxicity is a major issue, mostly from linezolid. It causes peripheral neuropathy in over 80% of patients and bone marrow suppression in almost half. So the key to managing BPAL is aggressive, proactive monitoring and being ready to frequently cut back or even pause the linezolid dose to manage these side effects. Well, speaking of BPAL's toxicity, that's the perfect lead into our next section. Managing adverse drug reactions isn't just some secondary task. It is absolutely central to keeping our patients on their treatment and getting them to that finish line, to a cure. This table right here is pure gold for your exams. For bedaquiline, the big one is QTC prolongation, so that means baseline and monthly ECGs, no exceptions. For linezolid, it's myelosuppression and neuropathy, so we need regular blood counts and neurological exams. And for cycloserine, you have to watch out for serious psychiatric side effects, which means careful mental status checks. Knowing these drug toxicity pairs and what to do about them is essential. It's all about proactive surveillance, not waiting for a disaster to happen. And just to really hammer home how serious these side effects can be, remember this: bedaquiline carries a black box warning for arrhythmias because of that QT prolongation. These are powerful life-saving drugs, but boy do they demand our respect and constant vigilance. So we've diagnosed the patient, we've built the regimen, and we have a plan for side effects. Now let's zoom out and put all this clinical care into the bigger picture, the programmatic framework that makes sure we actually achieve a lasting cure.
Programmatic monitoring is intense, and it's non-negotiable. Bacteriologically, we need a sputum smear and culture every single month. The culture result from month 5 or 6 is a massive checkpoint. If that culture is still positive, alarm bells should be ringing. It forces us to ask, is the patient taking their pills? Is the dosing right? Or, the scariest possibility, has new resistance emerged? This is how we catch treatment failure before it's too late.
And our work is not done when the patient takes their last pill. The goal is a durable cure. So, to confirm this, the program requires a 2-year follow-up period after treatment ends. Any patient who gets symptoms again is brought back for testing, and we do routine cultures every 6 months anyway. This is how we spot late relapses and confirm that we've truly achieved a successful outcome. We've covered a huge amount of ground on how to treat the individual patient in front of us. But as we head into our final summary, let's think about the bigger picture with this question. How do we take all this complex knowledge and use it to stop the next person from ever getting sick?
All right, let's do a quick rapid-fire review to lock in these key facts for your exam. The 2021 XDR-TB definition, that's MDR-TB plus resistance to an FQ and another Group A drug. Your first step when CBNAT shows RIF resistance, you start the MDR regimen immediately and send for more tests. High-level isoniazid resistance, Catchy gene mutation. The 2 killer toxicities of linezolid, myelosuppression and neuropathy. And if that QTC hits 510 on butaquilline, stop other offending drugs, correct electrolytes, and watch that ECG like a hawk. Mastering these is key. But remember, the real goal of all this knowledge is to break the chain of transmission. Every patient we cure prevents the next case. Thank you for your focus.